To help us understand a new pathway that the American Board of Internal Medicine is piloting, I'm joined by two guests. Dr. Erica Johnson is a board certified in internal medicine and infectious diseases. Currently, she serves as ABIM Senior Vice President for Academic and Medical Affairs. Dr. Jeffrey Berns is a nephrologist, member of the ASN Council, and former chair of the ABIM Nephrology Specialty Board. Erica and Jeff, thank you for joining me today to discuss the new ABIM pilot pathway.
Thanks, Tom.
Thank you.
Erica, before we focus on the pathway, can you help us understand ABIM's role in assessment?
Yes. So ABIM is an independent physician-led organization, and it has a governance structure in place that allows ABIM to serve as the vehicle by which physicians set standards for themselves. In that way, ABIM helps establish the requirements for eligibility for certification and also the standards that physicians must maintain in order to demonstrate that they're staying current in a discipline so that they can maintain that certification. But all of that is done with the input and oversight of physician volunteers who are practicing in the disciplines, who are really experts in their fields and help make those decisions on behalf of other physicians practicing in those disciplines.
So, Erica, you mentioned experts in their field. So, Jeff, you chaired the ABIM's Nephrology Specialty Board. Can you just give us a sense as to how that board helped the ABIM with decision making for nephrologists specifically, but then how that related to all more than 200,000 ABIM diplomates?
Sure, Todd. I think the process has changed a bit since I stepped away from ABIM as much as I had been involved previously. But the certification exam, the initial certification exam, as well as the other exams, are created by content experts, nephrologists practicing either general nephrology or some subspecialty within nephrology. Questions or items, as they're called, are created, are written. They're reviewed by others, edited by the ABIM team, and then pre-tested, if you will, for psychometric validity before they're live and used to make decisions about board certification. The process has changed. I think back when I was involved, the question writers, item writers tended to be almost entirely from academic disciplines, whether it was in nephrology or other disciplines. And over the years, that has evolved to be more inclusive and get other types of individuals who practice in different settings, be they rural or community practice, general nephrologists, glomerular disease experts, and so forth. But I think the underlying process is pretty much the same, and Eric sure can speak to that better than I. I just want to make a comment, and maybe Eric, you want to respond. There is also in the assessment process, particularly for fellows coming out of training, a great deal of dependence on the program director to make a global assessment about the trainee now graduated from fellowship in terms of their overall competence, their professionalism, their communication skills, their skill with procedures to the extent that they are required, or in the modern lingo, opportunity to train, and so forth. So you may want to comment on some of those things.
Absolutely. Thank you. If I could add just a bit to the process by which assessments are created, I agree with everything that you said, Jeff. And I did want to just call out how much more extensive that process of including different types of clinicians practicing in different types of environments on item writing task force, generating content for assessments has been, both in ensuring relevance of the content, relevance of the items on the assessments to the ways in which physicians practice, and also being as you said, a much more inclusive model in terms of having lots of different perspectives and voices so that the assessment outcomes are much more representative of physicians who are certified in the discipline. And it's also been a great way to expose physicians to governance. And many physicians who've been part of the item writing task forces have actually ultimately applied for, become volunteers in other elements of governance too. So it's a great way to really have lots more physicians involved in the process of setting standards. But yes, program directors are also a really critical step in determining eligibility. Program directors are the delegated authority of the board in terms of making that final statement as to whether the physician in training has achieved all of the competencies associated with that particular discipline. And so that step of attesting to achievement of competency and attesting to readiness to sit for the exam is the highest stakes decision in the whole process, even more so than taking the exam itself. It's really important. And that's delegated only to the program directors who indeed themselves are also diplomats of the American Board of Internal Medicine in that discipline.
So maybe we can use this as a transition to the pilot. And I've been not really referring to it by name because I know, Erica, the name has evolved a little bit. For those of you who are in our audience who are following these issues, it was originally dubbed Pilot Pathway E. But if you could just tell us the correct name and how should be referring to it, and then we can get into sort of the why and the how and what the experience has been.
Yes, it does have a long name. We wanted to be sure to include all of the elements in it and make it as descriptive as possible, but it's the competency-based medical education pilot for international medical graduates who have completed a medicine residency abroad and an ACGME accredited fellowship in the US. I'm just going to refer to it maybe as the CBME pilot or the pilot while we're talking today. You're welcome to as well. But because we have now five, ABIM has now five special consideration pathways, and they're sequentially lettered A through E, and this is the fifth offering. This is cataloged, if you will, as pathway E. That's where that letter comes from.
Erica, use of the term competency-based medical education just for this pathway seems to imply that the assessment or the training pathway is different than other paths to certification. And I'm not sure that it is, or if it is, maybe you can explain for us how it is different and why it's specifically competency-based when other pathways are not.
You're right, Jeff. All of the pathways are grounded in a framework that's building on some principles related to CBME. With this being the newest offering and us having the opportunity to name it in a way that calls that out, we wanted to be able to do that. Secondly, this one speaks directly to the types of the CBME framework that exists within accredited fellowships, which is a unique feature of this particular pathway. Physicians who are eligible for this pathway have completed their internal medicine training outside of the US or Canada, and they are completing their subspecialty in internal medicine fellowship training, though, in an accredited program that is based on a CBME framework. And in fact, because physicians who have done their internal medicine training abroad need a special exception in order to be allowed to train in an accredited fellowship. And that framework is set up by the ACGME as the exceptionally qualified candidate criteria. One of the elements of that process is that physicians who enter a fellowship as an exceptionally qualified candidate must, at the 12-week mark, undergo an additional sort of review by the CCC that is, or by the Clinical Competency Committee, that is based on the 6 core competencies. And so there is an additional step that is different for trainees who have done accredited internal medicine training that happens for these exceptionally qualified candidates. And so the title also helps call that out as well as an important part of the framework.
Yeah, I want to circle back to the relationship here with the ACGME, the Accreditation Council for Graduate Medical Education, because I do think that's an important part of this. And as you both said in the beginning, the role that residency and fellowship training program directors play in the whole process. Just to ask a fundamental question, I understand why ABIM now has 5 sort of pilot pathways and trying to think creatively about ways for people to get to certification. But why did ABIM want to focus specifically on exceptional IMG candidates?
So this particular pilot actually started as a question from the community from program directors in infectious diseases, actually, in the specialty in which I train. And this all happened actually before I joined ABIM as staff. I was chairing the infectious diseases board at the time, and we were just having a discussion about physicians who, as exceptionally qualified physicians, train in fellowships like infectious disease and nephrology and others who, at the end of their training, don't have an easy pathway to certification because of not meeting that accredited internal medicine training requirement and what options exist for them. And it was through the process of asking questions that it was clear that there was a really significant barrier to board eligibility for physicians and that this pathway might be an opportunity to show that physicians who had completed these accredited fellowships and had otherwise achieved the same sorts of standards related to the core competencies in that discipline as other physicians who had done accredited internal medicine training, and that if there was an opportunity to remove this barrier for physicians who had demonstrated that standard, then they'd also have the opportunity to demonstrate whether they could meet the standard of the knowledge exam, initially in internal medicine, of course, and then ultimately, upon succeeding with that, meeting the knowledge standard for the subspecialty in which they train. So the pathway was born out of a desire to remove this barrier to board eligibility for clinically focused international medical graduates. There had been another pathway in place for a long time, the faculty pathway, as it's commonly known, or pathway A. And the faculty pathway is an opportunity for physicians who don't meet the standard training requirements to allow a standard pathway to board eligibility to have an opportunity to become certified. And that pathway has its own set of criteria. But at the time, fewer than 200 physicians had become certified via this pathway across all disciplines. And so it was clear that this was not sufficient in meeting the needs, because at the time that ABIM's council was looking at creating this pathway, they estimated around 4,000 or more physicians who had trained in accredited fellowships since 2016 that had not met the underlying internal medicine accredited training requirement and thus didn't have an easy pathway to board eligibility.
Erica, I'm sorry, Todd, one of the concerns that ASN had raised prior to approval and implementation of this pathway, and I know that others in the GME community have had the same concern, is utilizing the very, very vague ACGME definition of exceptionally qualified, which is determined entirely locally. Basically, a program director makes an assessment that this is an exceptionally qualified candidate, and then they need to convince the GME committee at their institution to approve it. That's a very local activity. And one of the recommendations of ASN was appointing some kind of independent body that would sort of have more of a national standard and not be influenced by the particular needs of the institution. As there's been a lot of discussion about institutions that have a hard time filling their fellowship spots, may have a somewhat looser definition of exceptionally qualified than another institution that either feels like they have a different mission or doesn't have as much difficulty filling fellowship positions and so forth. So maybe you could just comment upon the rationale that ABIM uses to rely really entirely on that ACGME definition, and then maybe you can comment on what ABIM is doing, if anything, to sort of look back at how that definition is being used to make sure that people who come through this pathway are indeed exceptionally qualified. Because once that exceptionally qualified label has been applied, which is prior to them even starting fellowship, there's not a need to reassess that exceptionally qualified criteria again, ever.
That's absolutely right. But we need to remember that physicians are already entering fellowships via these pathway anyway, and that institutions already had this process in place for determining eligibility for starting fellowship for internationally trained physicians using these exceptionally qualified criteria as common program requirements by the ACGME. ABIM's role in the process is at the end of training. And at the end of training, all physicians being equal, the program director is at that time attesting to the board whether or not that physician has met the knowledge, skills, and judgment standards in that discipline in order to be eligible to sit for the exam. And so in that way, we were setting this up as a model that allowed for all physicians who demonstrated the same standard at the end of training being eligible to take an exam. You're right that there are lots of different institutional, I guess, variations with how the exceptionally candidate criteria are employed or deliberated upon, how decisions are made around which physicians to accept into fellowships and which physicians not to. All of that is locally derived, but all of that is happening at the level of the programs, and all of that is being, the oversight of that, I should say, is all at the level of program oversight. So sort of away from ABIM's purview in terms of individuals and eligibility standards. But I will say that some of the metrics that we have for assessing the pilot are the things that program directors tell us about trainees. Milestone achievement, that overall global assessment of competency at the end of training, those types of things we have on all candidates. And of course, all candidates have to be satisfactory or better in those standards in order to be eligible. But that's information that we can collect on all of the trainees who are verified prior to becoming eligible to take an exam. And one of the metrics that we can look at as we're continuing to look at outcomes related to the pilot.
It's interesting because I'm sitting here thinking about all the different players in this process. So clearly, ABIM has a very well-defined role here. We've talked a lot about the ACGME and the role that it plays in accrediting the residency and the fellowship programs. There's then the organizations that support residency program directors. And then you have the Association of Program Directors in Internal Medicine that's really trying to support the program directors. And then you have the different subspecialty societies and within nephrology, ASN, and the relationship it has with the fellowship training program directors. So it sounds like one of the challenges, and this is a broader conversation, is how do organizations like ASN help provide the support both for the fellowship training program directors, but then also for the fellows that they may not be getting it at a local level. And I know there's examples in some specialties. So I think that is a discussion for us to have at one point. I guess my question is just sort of shifting gears. You had said that the faculty pathway had about 200 participants. So to date, how many participants have there been in the pilot?
Yes, at the time we had done the initial analyses related to this, the faculty pathway had fewer than 200 participants who'd been approved since 2008, which is when the current criteria for the faculty pathway had been in place. And now that number's a little closer to 240. The pilot was developed over the course of several years because there was a lot of stakeholder feedback involved in refining the pilot. But the CBME pilot, the new pilot special consideration pathway, since its implementation in September 2025, there have now been more than 160 physicians who've become eligible for internal medicine, the internal medicine certification exam via this pilot. Of course, physicians initially become eligible for the internal medicine exam. They can then register and take that exam. Once they're successful with that exam, they then become eligible for the subspecialty exam and the discipline in which they trained. So yes, more than 160 physicians. It's been a really robust response so far. And there's a lot of nephrologists represented in that number. Over 40% of that 160 plus physicians is represented by physicians who have trained in accredited nephrology programs. So that's been really exciting. In terms of other disciplines that are highly represented, if we add up all of the different cardiology and cardiology tertiary disciplines like interventional cardiology, adult congenital heart disease, et cetera, cardiovascular diseases as an aggregate would be next. They're around 18% of the participants who've been approved for eligibility via the pilot thus far, and then closely followed by geriatrics and infectious diseases, which are each around 15-16%.
Erica,
Together, those
no,
Oh,
go
I'm sorry. I
ahead.
was going to say together, all of those disciplines that I named make up around 90% of those physicians thus far who've become eligible via the pathway, with the remaining around 10% being spread out over across many of the other certificates that ABIM oversees. Sorry, Jeff.
Yeah, sure. Given the newness of the program, I'm pretty sure that nobody who's completed a nephrology fellowship program has yet taken the initial certification exam, but I guess potentially in geriatrics is a one-year fellowship. Is that so? And if so, I'm just wondering if you've gotten any early signals about pass rates compared to people who've gone through more traditional pathways, but I recognize it may be too soon to know that.
Yes, too soon. So this pathway is brand new. We're talking about 9 months of data so far. So this first cohort that I mentioned, I'll have the opportunity to register for the internal medicine exam that's going to be administered this August 2026. So the majority of these 160 physicians will take their first ABIM exam in August 2026. Those that are successful on the internal medicine exam can then take a subspecialty exam the following year. So no nephrologists, geriatricians, ID physicians, cardiovascular disease physicians, or other disciplines have taken those exams yet, but we suspect that that'll be coming in 2027. The majority of the participants so far have completed training in 2023 through 2025 in terms of their fellowship training. So we're seeing a lot of more recently trained physicians, more so than physicians who had trained closer to when the exceptionally qualified candidate criteria were first implemented in 2016. And then another really important data point to share, I think, is that when we've asked these participants about their practice, all but two have been practicing in the US, and many are practicing in their discipline. And they're practicing in a variety of different institution types, both in the inpatient and outpatient setting. So these are physicians who are working, but it will be interesting to see how their practice patterns might change when they have the opportunity to be certified in their disciplines.
So just maybe to help listeners who aren't completely familiar with all the details of the program, individuals who go into this pathway, whether they've previously, years past, completed fellowship training or are going into fellowship training now, the process will be past the ABIM internal medicine certifying exam first. And then once they have passed that, are then eligible to take and hopefully pass the subspecialty exam.
That is correct. So for any special consideration pathway, once it becomes implemented, the physicians who fulfill the eligibility criteria at the time of implementation, which would include those physicians who've already completed training, as well as physicians who might fulfill those criteria in the future, or can all be considered, as long as they meet the criteria at the time that they apply for the pathway. And at the time that they apply for the pathway, meet all of the criteria, are approved, they become eligible initially for the internal medicine exam, because that internal medicine exam is foundational and demonstrating achieving the knowledge and standards associated with internal medicine is still necessary in order to then be open up eligibility to a subspecialty of internal medicine. But
But
yes, you had all of that exactly right, Jeff.
But I want to make sure I understand the timing though, because it sounds like for this first group, the internal medicine initial certification will be in August. And then if they pass, it wouldn't be until the fall of 2027 that they would take the nephrology fellowship board. Do I have that correct?
That's right. You have that correct. So they would take that internal medicine exam. Upon getting those results, they had passed. They then become board eligible for nephrology or for the subspecialty in which they trained. And so with that board eligibility, they can then register to take the exam, but they also have that same sort of board eligibility that a physician who maybe did accredited internal medicine training and then accredited nephrology training had already passed the internal medicine exam, maybe in their first year of nephrology fellowship and came out of training, they have that same sort of board eligibility for nephrology. And so it's analogous to how you might think of those physicians.
So, Jeff, can I ask you a hypothetical? So let's pretend you're running a dialysis organization in a big city in the East Coast, and one of these candidates comes to you today. How would you think about them as an employer?
It's a great question. I think some of that would be what have they been doing in recent years? So if I understand the pathway, somebody could have completed nephrology fellowship 5 years ago or 6 years ago, and now be eligible to take the internal medicine exam and then the nephrology exam. If they have not practiced nephrology in 5 or 6 years in any way, they're still eligible to take the nephrology exam if passing the internal medicine exam, I think. In that case, I would probably be reticent to employ them. I think somebody who just completed fellowship a year ago and has been, or two ago, and has been practicing nephrology, including dialysis care in some setting and then became board certified in nephrology, I would be less reticent to at least consider them for employment or some activity in a dialysis unit. And I think the same principles would probably apply to other employers, whether it's a practice, large or small, or an academic setting. I think that the recent clinical activity, I think, is going to be vitally important.
Given the federal government's sort of changes as to how it's thinking about immigration and visas, how is that affecting this program, or is it too soon to say?
So I think it's still too soon to say because I think the robust response that we've seen thus far in just applicants to the program and the fact that this pathway that's been in place for about 9 months is outpacing longer standing pathways that have been in place for decades. It suggests that there's a real need here and that perhaps we're not seeing much change. But many of these policies are still new, and I think we just haven't been able to see the full impact of them. Also, I wanted to add that an important goal of the pathway really was just removing a barrier for physicians. As I had shared before, many of these physicians that have been approved already, almost all of them are already practicing in the US in the disciplines in which they've trained, but without certification. And so the pathway is yielding an opportunity for them to demonstrate the knowledge, skills, and judgment associated with being a nephrologist or other type of subspecialist on the exam, and then be able to join a continuing certification program where they're going through regular cycles of meeting assessment and activity. So it actually is, I think, a framework that is much more conducive to the types of professional development, much more conducive to our obligation to the public in order to demonstrate a credential that shows that we have certified expertise in the discipline in which we say we practice, and offers an opportunity, I think, as well to maybe mitigate some of the vulnerabilities that internationally trained physicians are more likely to experience than other physicians in our current healthcare system in terms of having more opportunities for career growth, career advancement, and such. So I do hear the point about physicians who maybe have had a longer period of time since training and whether there might be concerns if they're not practicing. But many of these physicians are practicing, and I think that that same concern would exist for any physician, including physicians who train in an accredited internal medicine program and then in an accredited nephrology fellowship, and then maybe made a decision to delay practice for some time, but still is board eligible for at least a period of 7 years from when they meet all of the eligibility requirements for the exam. So I see this pathway as just removing a barrier that was in place, perhaps unfairly, for physicians who otherwise are well trained and are able to demonstrate the same standards as physicians who've completed accredited internal medicine training.
So, Erica, recognizing that being board certified in internal medicine and a subspecialty discipline by the ABIM opens up a lot of career opportunities for people that are not necessarily available to them without certification. And now there's going to be, to some extent, three very separate cohorts of board eligible, board certified physicians. Somebody who did a fellow for an international graduate who came to the United States, did a fellowship, and has been practicing for some period of time, potentially in their subspecialty discipline. There's going to be a group of international graduates who do 1 or 2 years potentially of practice in the United States, never having participated in the US healthcare system previously. So that's people who are now coming into fellowship. They can do geriatrics for 1 year or nephrology or infectious disease for 2 years, and they can go out and practice once they've met the board eligibility requirements and taken and passed the exam. And there's everybody else who has done a 3-year residency in internal medicine and then a fellowship in the United States and has at least 4 to 5 years or more of experience in the US healthcare system being supervised. So I'm curious, and this was, I think, an issue that ASN had raised as this was being discussed. ABIM going to have any assessment of the quality of care outcomes and the practice patterns and so forth of these very different cohorts to make sure that board certification is board certification is board certification, regardless of which pathway you've taken to get there.
I think it's important to say that as you've described the different cohorts of physicians, ultimately all of these pathways lead to the same standard, the same certification exam in internal medicine and ultimately in the subspecialty that everyone must achieve in order to be certified in that discipline and ultimately to go to the next step. And so in that way, the exam is a bit of an equalizer. It's a way that everyone can demonstrate that they're all meeting that same set of standards related to knowledge, skills, and judgment associated with the discipline. Also, I think one of the really key features of the CBME pilot in particular, the new pilot that we've been talking about today, is that the physicians who go through the pilot will do at least 12 months or more of an accredited GME program with educators who are certified in the discipline by the ABIM who are observing them in a competency-based framework, right, making regular assessments as to whether they are achieving competency. And then ultimately at the end of the training, there is that program director who is also a board certified physician in the discipline saying, yes, this person meets that global standard of having achieved all of the knowledge, skills, attitudes, and judgment of a physician practicing in this discipline. So there are lots of opportunities for observation along the way. Even with the faculty pathway, special consideration pathway, because of the requirements for that, one of the requirements is that the physician be practicing in place for at least 3 years at the institution, being observed by physicians, department chairs or program directors in the discipline who are also diplomats of the ABIM in that discipline who are attesting to that physician demonstrating the knowledge, skills, attitudes, and judgment of a physician who practices in that, who is certified in that discipline. I think in all of these ways, there are opportunities for people to demonstrate competency, for that to be verified by someone who is a diplomat of ABIM, who has the authority to do that. And then ultimately, everyone takes the same exam. Everyone has to demonstrate the same knowledge associated with the discipline on the exam. And that really is an important way to show that if you have achieved that standard, you'll pass that exam and you will be certified. And then once we're certified, once we're all diplomats, we all continue to have the same sorts of set of standards that we have to maintain in terms of activity and assessment in order to continue to be certified. I think
So,
there's something to be said for that.
so Erica, how will ABIM assess both the performance on the exam for this cohort of people, but also a follow-up question is going to be just overall, since it is a pilot, just getting a better understanding as to how you're thinking about the future of the pilot, how you're going to assess it, feedback from the community, et cetera.
Yes, so these are important metrics, and part of the metrics that council and its oversight of the pilot is, regularly looking at, but for all candidates, including candidates who become eligible via special consideration, we're looking at registration for exams, both internal medicine and ultimately subspecialty. We're looking at performance on those exams, and then we're looking at things like, as I had mentioned before, from training, milestone ratings, overall clinical competency ratings by the program directors. And we're also looking at, for people that become diplomats, their engagement with the activity and assessment components of the maintenance and certification or continuing certification program. So all of that is collected and shared to provide a snapshot of the discipline for each of the specialty boards and advisory committees that oversee each discipline. It's prepared as a snapshot for the council, which has oversight of all of the programs. But it's also a part of the regular updates that ABIM shares with the community in terms of continuing to report on the outcomes related to the pilot. We are invited to talk about the pilot in avenues like this. ASPN has been a really fantastic partner in helping share information about the pilot, but other specialty societies as well also have an interest in getting this information out. And I think as we talk about the pilot and as we start to accumulate some of the data related to registration for exams, performance on exams, things like that, those are also data that we can continue to share and aggregate. But everything that we have seen thus far in terms of our experience with other pilots and in terms of oversight of disciplines in general leads me to believe that this cohort of physicians will likely have similar performance on the exam as any other cohort of physicians who become candidates for eligibility for ABIM exams. But yes, it is something that we will be looking at closely and will continue to share as part of the process of evaluating this pathway.
So Erica, has the ABIM board or councils established criteria for determining success or not of the pathway? Or is that something like at the end of, I think it was a 5 or 6 year period, ABIM will look at the data and then make a decision whether they're happy with the outcomes or not? And how will you approach this if the success is very, very different in one subspecialty versus another?
Right. So with any pilot, I think we go in with the idea of thinking about feasibility, scalability, and generalizability. The council did establish a period of 5 years for looking at data just to allow for enough time, with some fellowship programs being longer than others, and then also recognizing the period of board eligibility and the need to certify in internal medicine before certifying in a subspecialty. So that period of 5 years felt like a minimum in terms of having the right types of data to really fully assess. But they're looking at data regularly. And in fact, since implementation in September, every time council has met, we've been able to share updates with council about the pathway. And then also the pathway had to be approved by the American Board of Medical Specialties Committee on Certification as well. And that committee, COCERT, also asked for an interim update on the pathway at the 2 or 3 year mark. So I think there are regular steps along the way where we'll continue to be looking at data throughout. But the main things that I think would suggest success at the end, as I kind of think about it, is, are people using the pathway to become certified? And so far, it looks like from the response that yes, it seems to be meeting a need, and it's meeting a need in multiple different disciplines. And then are they becoming certified via the pathway? And that's a question we still can't answer. This first cohort is just now registered for the exam in August. So we'll start to get some early signal from then, but it's going to take a few years for us really to see if this is indeed a viable pathway to certification in internal medicine and the subspecialties.
Yeah, then another question that has come up is about state licensure, and recognizing that board certification, at least the last time I had a conversation about this, is not required in any state for licensure. Maybe that's changed. Each state licenses its physicians their own way, and at least in some states, I think actually many states, 1 and even 2 years of graduate medical education may not be sufficient for licensure. And some states have different criteria for international graduates versus US graduates. So have you had a chance to sort of get an assessment of what the lay of the land is going to be for path to licensure for those who go through this pathway? And will there be unique impediments to licensure for those who do?
Thank you, Jeff. That's a great question. In fact, I remember when you asked me that question during the nephrology board meeting. And as a result, we started tracking a new data point, which we now show when we show aggregate data, for example, with council or other groups that ask us. So we're starting to more closely track the states in which physicians are telling us that they're practicing at the time that they apply for the pathway. I'll just share that we've seen some really strong signal in New York, and that also matches up with some data that we had about the physicians who we thought would be eligible before the pathway was implemented when we went and surveyed them, the physicians from that group of more than 4,000 that I had mentioned before. A lot were practicing at the time in New York, Florida, and California. They also happen to be very large states. And we're seeing strong signal in those same states with people who've become eligible via the pathway. Again, not surprising because they're large states, large jurisdictions. It is an important data point. You're right that there are differences in the requirements for years of GME training for licensure, and that might impact physicians who would like to become eligible via this pathway, who train in shorter or longer fellowships. Something to watch, but something that still is separate from the process of certification and being eligible for certification. Physicians are required to have a license, a clinical license to practice medicine at the time that they are meeting eligibility criteria. If anything, this might affect the distribution of physicians who become eligible via this pathway in terms of where they practice, but it's much more of a licensure state medical board issue more so than a certification issue.
Sure.
So my final question, you'd mentioned that about 40% of the participants to date are nephrology. What is the number where ABIM takes a step back and says, well, wait a second, I'm just going to make up a number. More than 50% of the participants are from one discipline. Therefore, this may not be meeting our needs. There must be something different about, in this case, nephrology from, say, these other disciplines. Perhaps we need to look at this just from a fresh perspective. And Erica, why don't I ask you that question first? And then Jeff, I'm curious as to how you would think about it, both from an ASN perspective, but also given your background, both with ABIM, but also medical education.
Yeah, sure. I think that there are lots of different ways to explain why we might be seeing such strong representation in nephrology and some other disciplines, ID, geriatrics, cardiovascular disciplines relative to others, but particularly in nephrology. And I think that some of it is that there are a lot of internationally trained physicians who are in nephrology. I think some of it is that nephrology has been a really great partner in helping to have healthy discussions in the community about this topic, in particular ASN. I think you have really amplified the message about this pilot, both in ways, even in critical ways that have helped us strengthen the pilot or the messages about the pilot or the types of questions that people have about the pilot. I think that the demonstration of support, just in the number of participants who are trained in nephrology, who might become board certified nephrologists because of this pilot, seems like a really fantastic outcome. And I'm heartened to see that. I really I know that there are a shortage of nephrologists and infectious disease physicians and geriatricians practicing right now, and I'm really glad to see that there might be more certified physicians in these disciplines and others to help with addressing some of the workforce needs in our disciplines. When I think about the data from the faculty pathway, we also have seen the strongest signal in a single discipline for that. And I'd say internal medicine represents close to half of the physicians who become certified in via the faculty pathway. There's also strong signal in that pathway from medical oncology as a discipline. So each of the pathways is just a little bit different in terms of the physicians, and some of it honestly might just be how messages about the pathway are getting shared to people who might be eligible and might represent opportunities for improvement for us to do that a little bit better. But yeah, I see that as a win that there are more than 40% of nephrologists who've become eligible via this.
Jeff, curious as to your response.
Yeah, I agree to a large extent. I think this can be a win if those who become board certified in nephrology through this pathway practice nephrology and practice nephrology really, really well. In the United States, clearly there's a need, and as Eric said, nephrology has a very large fraction of its community who are international medical graduates. There is a risk, and one that comes to mind, and maybe it's completely unrealistic, is that international medical graduates who want to come to the United States know that there's a great need in nephrology, get into a program in nephrology, not with any great interest in nephrology or even an interest in practicing nephrology, but see it as a path to board certification in internal medicine without having to go through the traditional pathways of 3 years of internal medicine residency and then 2 years for nephrology fellowship, and end up not practicing nephrology, but practice internal medicine, which if they're board certified, they're perfectly eligible to do. So I think we'll just have to see how that plays out in time. And maybe that's not necessarily a bad thing. If nephrology fellowship programs get highly skilled fellows who learn nephrology, and whether they practice or not, maybe yes or no in terms of whether that's important to the discipline. I personally think it is. But that is a potential risk with such a heavy dominance of nephrology that the risks of this pathway are also accentuated potentially for nephrology as a discipline, and obviously less so for cardiology or oncology or other disciplines where this is being used to a much lesser extent.
Eric, I have a feeling you want to respond to that.
Oh, no, I was just going to add that I think one of the things that the pathway will help us answer is that question of how physicians practice based on becoming eligible and ultimately certified via the pathway. So that's data we'll have, and we'll get to see if the nephrologists who become certified via this pathway are indeed practicing in nephrology. Many of them are already who trained in nephrology, and we'll see if this pathway allows them to continue to do that, or if they can move, have more job opportunities for movement within nephrology, or if they practice in another field like hospital medicine. But either way, more physicians who are certified, who are practicing in any discipline, because every discipline really has a physician shortage right now, does seem like a win. In my hospital, when I do infectious diseases consult services, it seems like ID and nephrology, we're always consulting on the same patients because when we're rounding in the afternoon and we're going to the different team rooms or the different patient rooms, we're always seeing the same patient. So I know that and I see that the nephrology fellows are working really hard, just like the ID fellows, just like all physicians. But 2 years of training, taking care of lots of sick patients in the hospital and in the clinic, coming out of nephrology fellowship with those skills to do that and then being certified, that just seems like a really important opportunity to help take care of patients better, having more physicians trained in the skills of nephrology. I'm looking forward to seeing that as a potential outcome to this pilot.
Well, Erica, Jeff, thanks for a very insightful discussion. I really appreciate all of your time today.
Thanks.
Thank you. Enjoyed the conversation.
This podcast should not be used in any medical emergency or for the diagnosis or treatment of any medical condition. If you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment, please consult your doctor or another qualified healthcare professional. Views expressed on this podcast are those of the speakers and not necessarily those of the American Society of Nephrology.